Good morning, students. We will continue our topic chemistry of proteins, competency number 5.2, and today's subtopic is plasma proteins. Total plasma proteins in normal individual ranges from 6 to 8 grams per deciliter. These plasma proteins are composed of albumins, globulins, and fibrinogen. First, about albumin. The name albumin is derived from white precipitate formed when egg is boiled. This word is derived from Latin word albus, the meaning is white. Albumin constitutes the major part of plasma proteins. It has one polypeptide chain with 585 amino acid and has molecular weight 69,000 Dalton. It is elliptical in shape. The normal level of albumin in plasma is 3 to 5 grams per deciliter. Albumin is exclusively synthesized in liver cells or hepatocytes. Half-life of albumin is 20 days. Liver produces about 12 grams of albumin per day, and this is about 25% of total hepatic protein synthesis. Albumin is present in plasma as well as it is also found in CSF and interstitial fluid in small quantity. Now we will study the functions of albumin. The first function of albumin is it exerts colloidal osmotic pressure. The total osmolarity of serum is 278 to 305 milliosmol per kg, and it is about 5000 mm of Hg. This is produced mainly due to salts and proteins. Salts which can pass from intravascular to extravascular compartment easily, and proteins mainly the albumin which cannot pass from intravascular to extravascular spaces. As the salt passes from intravascular to extravascular compartment, the osmotic pressure exerted by salts inside and outside the vascular compartment will cancel each other. But the proteins which cannot pass, and this protein exerts effective osmotic pressure in the vascular compartment. In the vascular compartment, the concentration of protein is more. Therefore, it exerts 25 mm of Hg pressure in the intravascular compartment, and out of this 80% of the pressure is exerted by albumin. Now this is called as effective osmotic pressure, which is nothing but a difference between the pressure of intravascular space and extravascular space, and the maintenance of blood volume is dependent on this effective osmotic pressure. Now we will see the clinical applications of this edema. Accumulation of fluid in the interstitial space is called as edema. Basically, edema is seen in two conditions. First is hypoalbuminemia, that means decrease in albumin in plasma, and chronic venous congestion in cardiac failure. Now, this edema depends on the pressure difference between intravascular compartment and interstitial spaces. In the intravascular compartment, the pressure is maintained by balance between blood pressure and effective osmotic pressure exerted by albumin. In the intravascular compartment, the blood pressure is different at arterial end and venous end of capillaries. At the arterial end of capillaries, blood pressure is 35 mm of Hg and effective osmotic pressure due to albumin is 25 mm of Hg. So net pressure at arterial end is calculated by formula blood pressure minus osmotic pressure. So here 35 minus 25 is plus 10 mm of Hg is the net pressure at arterial end of capillaries. At the venous end of capillaries, blood pressure is lower, so it is 15 mm of Hg, and effective osmotic pressure is same 25 mm of Hg, which is due to albumin. So if you calculate net pressure here, which is equal to blood pressure minus osmotic pressure, So you will get 15 minus 25 is equal to minus 10 mm of Hg. So net pressure at arterial end is plus 10 mm of Hg, and net pressure at venous end of capillaries is minus 10 mm of Hg. So at the arterial end, the water is expelled by a pressure of 10 mm of Hg from intravascular space to interstitial space, and at the venous end, the water is imbibed or enter from interstitial space to intravascular space with the pressure of 10 mm of Hg. This is the diagrammatic representation. Same, blood pressure at arterial end is 35, osmotic pressure is 25, so net pressure is 10. So water comes out from intravascular compartment to interstitial space by a pressure of 10 mm of Hg. At the venous end of capillary, the blood pressure is 15, effective osmotic pressure is 25, so net pressure is minus 10. So with the pressure of minus 10, the water is entering on the venous side of the capillaries. Therefore, here the number of water molecules escaping at the arterial end are equal to the number of molecules entering on the venous side of capillaries. Therefore, there is no accumulation of fluid in the interstitial space. Now we will see edema. First, edema is due to hypoalbuminemia. If albumin concentration is serum is reduced, the effective osmotic pressure is decreased. Then water return to the blood vessel is diminished, leading to accumulation of water in the interstitial space, leading to edema. So this is the diagrammatic representation of edema due to hypoalbuminemia. Here at the arterial end, blood pressure is 35 and osmotic pressure is 20. Here osmotic pressure decreases from 25 to 20 due to decreased albumin. So if net pressure here is plus 15 mm of Hg, so water comes out from arterial end with a pressure of plus 15 mm of Hg. In the venous end, the blood pressure is 15 mm of Hg and osmotic pressure is 20. So net pressure is minus 5 mm of Hg. So water enters into the vascular compartment with a pressure of only 5 mm of Hg. Hence, more water molecules are coming out at the arterial end and less water molecules entering into the capillaries from venous end. This leads to retention of water in the interstitial space, leading to edema. And this is the mechanism of edema in hypoalbuminemia. Now we will see causes of hypoalbuminemia. So first and most important cause is protein losing enteropathy, means here we will take large amount of protein in the diet, but that albumin which is present in the diet is not digested and absorbed from our alimentary canal, and it is lost into the stool, which is called as protein losing enteropathy. Malnutrition, it is the most common cause of hypoalbuminemia, especially in children of poor families where the protein intake is less, so albumin synthesis is decreased in this patient, leading to hypoalbuminemia. Next cause is kidney diseases, especially nephrotic syndrome. Normally the albumin is not filtered through the glomerulus, but in kidney diseases the glomerular basement membrane get damaged, so albumin can easily filtered through the glomerulus and excreted into the urine, leading to deficiency of albumin in the serum. And last case is cirrhosis of liver. As I have already told you that albumin is exclusively synthesized in the liver. In cirrhosis of liver, albumin is not synthesized, and this leads to decreased albumin level in the serum. Now we will see a case where there is venous congestion. In venous congestion, at the arterial end the blood pressure is normal, but at venous end, if you see at venous end the normal blood pressure is 15, but due to congestion or accumulation of blood in the venous side, the blood pressure at the venous end of capillaries increases from 15 to 20 mm of Hg. Therefore, the net pressure on the venous side is 5 mm of Hg, and therefore more water escapes from arterial end from capillaries and less water enters through the venous end of capillaries, leading to accumulation of water molecules in the interstitial space and edema. After seeing the function of albumin, that is choroidal osmotic pressure, next function of albumin is transport function. Albumin is a carrier of various hydrophobic substances in the blood, because albumin or proteins are hydrophilic in nature. Therefore, we can see albumin transports various non-esterified fatty acids, means free fatty acids, which are hydrophobic in nature, unconjugated bilirubin, some drugs like sulfa drugs, aspirin, salicylate, diacomeral, phenytoin, all these drugs are hydrophobic in nature, so they can be transported to various parts of the body by binding with albumin. Some hormones like steroid hormones and thyroxine, they are also transported by albumin, and some metal ions like copper, calcium and other metal ions are also transported by the albumin. So albumin acts as a transporter of various wide variety of substances in the blood. Now we will see the clinical applications of this transport function. First is blood-brain barrier. In the blood, just I have told you, fatty acids binds with albumin and they get transported. Now in our blood, in our body, the blood-brain barrier exists, which separates our blood from brain. The albumin fatty acid complex cannot cross the blood-brain barrier, and hence fatty acids are not taken up by the brain as a source of energy during starvation. During starvation, other tissues utilizes easily fatty acids as a source of energy, but due to existence of blood-brain barrier, the fatty acid bilirubin complex does not cross this barrier, and fatty acids are not used as a source of energy by the brain, and hence brain utilize only glucose as a source of energy. Next clinical importance is kernicterus. As I have told you that albumin also transports unconjugated bilirubin in the body. So kernicterus means deposition of unconjugated bilirubin in the brain. Normally albumin bilirubin complex cannot cross the blood-brain barrier, but if a patient is having increased unconjugated bilirubin, in this case if we give some drugs like aspirin or any other drug, there is a competition between this drug and unconjugated bilirubin to bind with albumin. During this competition, some drugs will displace the bilirubin from albumin binding site, and hence this unconjugated bilirubin becomes free, and when this unconjugated bilirubin becomes free, it is lipophilic, so it can cross the blood-brain barrier easily and get deposited in the brain, especially in newborns. Deposition of unconjugated bilirubin in the brain leads to a disease called as kernicterus, which may leads to mental retardation. Next is drug interaction. It is seen when two drugs are consumed for a long period of time. In the blood, albumin acts as a transporter of various drugs. When two drugs transported by albumin are administered together or taken together, then there may be competition for binding with albumin between these two drugs, with consequent displacement of one of the drug. So one of the drug is displaced. Such an effect may lead to clinical significant drug interaction, or the efficacy of the one drug is decreased because it is not transported by albumin to various tissues. Now such drug interaction may be seen in few drugs. Example of one is given here. between phenytoin and dicomirol. Phenytoin is an anti-epileptic drug and dicomirol is a anticoagulant drug. Protein bound calcium. Total serum calcium is 9 to 11 milligram per deciliter. In the serum, total calcium exists in three forms: ionized calcium, protein bound calcium, that is albumin bound calcium, and calcium bounds with anions called as complexed calcium. So total of these three form is 9 to 11 milligram per deciliter. In case of hypoalbuminemia, the protein bound calcium or albumin bound calcium portion is, that fraction is decreased, and hence patient will have hypocalcemia. That means if a patient is in hypoalbuminemia, the patient will also have hypocalcemia. Here the ionized calcium level is normal, therefore tetany is not seen. If albumin level is decreased by 1 gram per deciliter, then calcium level decreases by 0.8 milligram per deciliter. That you should keep in mind while if you see a patient of hypocalcemia. So clinical importance of this is that if you want to correct hypocalcemia in the patient, you have to give calcium therapy, along with you have to correct the albumin levels in this patient. Next function of albumin is buffering action. All proteins have buffering capacity. Because of high concentration of albumin present in the blood, it has maximum buffering capacity. Albumin has total 16 histidine residues which contribute for this buffering action. Nutritional function. All tissues will take up albumin by pinocytosis. That means they will engulf albumin as it is without its breakdown. After pinocytosis, the albumin enters in the cell, and inside the cell the albumin is broken down into various amino acids. So albumin may provide essential amino acid to the various cells. Therapeutic use. Next function is therapeutic use. Human albumin is clinically useful in treatment of some diseases like liver diseases, where albumin synthesis decreases, hemorrhages when serum albumin is lost, shock and burns. After completing albumin, we will go to globulins. Various globulins are thyroxine binding prealbumin. It transports steroid hormone, thyroxine and retinol. Next globulin is retinol binding proteins. It transports retinol, that is vitamin A. Next is thyroxine binding globulin. It transports only thyroxine. Next is transcortin or cortisol binding globulin. It transports cortisol and corticosterone hormones in the blood. Another type of globulins are haptoglobin, which transport free hemoglobin to liver, transferrin, which transport free iron, hemopexin, which transfer free heme to the liver, prothrombin, it activates fibrinogen and various coagulating factors like factor 8, 7 and 5. Next globulin is ceruloplasmin. It is alpha 2 globulin. Ceruloplasmin is synthesized mainly by hepatocytes, and small amount is also synthesized by lymphocytes and macrophages. Ceruloplasmin is a holoprotein which is made up of apoprotein and cofactor. Here the apoprotein is a protein part and cofactor is copper. So after synthesis of peptide part of ceruloplasmin, that is apoceruloplasmin, the copper is added into it with the help of enzyme ATPase. So this, remember, this ATPase enzyme is very important in the synthesis of ceruloplasmin holoprotein. Now functions of ceruloplasmin. Ceruloplasmin is also called as peroxidase enzyme. It acts on ferric iron and convert it into ferrous iron. After converting into ferrous iron, it will add this ferrous iron into another protein called as apotransferrin and convert this apotransferrin into transferrin. So this transferrin is also a example of holoprotein, in which the protein part is apotransferrin and cofactor is ferrous iron. 90% of the copper in the plasma binds with ceruloplasmin, remember this, and only 10% binds with albumin. So albumin act as a transporter of copper also. Ceruloplasmin also act as an antioxidant in the plasma. Now we will see the clinical importance of ceruloplasmin, that is Wilson's disease. It is a inherited autosomal recessive disease with an incidence of 1 in 50,000. The basic defect is mutation in the gene coding for enzyme copper binding ATPase, which is required for synthesis of holoprotein ceruloplasmin, just we have seen. So due to mutation in the gene, this enzyme is not, ATPase enzyme is not synthesized in the patients of Wilson's disease. So due to defective ATPase enzyme, ceruloplasmin is not synthesized and hence the level of ceruloplasmin in the blood decreases. Just now I have told you that 90% of the copper is present in the ceruloplasmin. So this copper is not utilized for ceruloplasmin synthesis and hence the level of free copper in the blood increases. In the Wilson's disease, the ceruloplasmin level decreases to less than 20 mg per deciliter. Now clinical features of Wilson's disease. The clinical features of Wilson's disease is due to deposition of copper in various tissues. First is cirrhosis of liver. Here the copper get deposited into the hepatocytes, leading to degeneration and cirrhosis. Next is lenticular degeneration. Here free copper get deposited into the basal ganglion, leading to lenticular degeneration and neurological symptoms. Next clinical feature is Kayser-Fisher ring. This is greenish or golden colored ring which is seen around the cornea due to deposition of free copper around the cornea. So these are the clinical features of Wilson's disease. Here the Kayser-Fisher ring is the diagnostic sign of Wilson's disease. Now treatment of Wilson's disease, you can give diet containing low copper. We can also inject D-penicillamine in such patient. This D-penicillamine binds with free copper and forms a harmless substance which can be easily excreted through the urine. You can also give zinc in such patient in the diet, which decreases the absorption of copper from the diet. After completing ceruloplasmin globulin, we will see next globulin is C-reactive protein, CRP. It is named C-reactive protein because it was first obtained from C polysaccharide of the capsule of pneumococci. It is a beta globulin. Function of this is it can stimulate the complement activity and macrophage phagocytosis in the body. Clinical importance of C-reactive protein is it is synthesized during inflammation. When the inflammation subsides, CRP level falls. CRP levels are especially high sensitive CRP or high sensitive C-reactive protein level in the blood has positive correlation in predicting the risk factors of coronary artery disease. That means in coronary artery disease, the high sensitive C-reactive protein, which is a variant of CRP, increases. Next globulin is alpha-1 antitrypsin. It is synthesized in the liver. It is a glycoprotein with molecular weight 50 kd. It forms a bulk of molecule in the serum having alpha 1 mobility. Its serum value level is 75 to 200 milligram per deciliter. Now function of alpha 1 trypsin is very important. This alpha 1 antitrypsin inhibits proteolytic enzymes in the blood and protect our body from digestion. Our body organs are made up of proteins. If the proteolytic enzymes are present in the blood, then they will enter in the various tissues and these proteolytic enzymes will digest the various tissues. So this alpha 1 antitrypsin inhibits all these proteolytic enzymes. It will inhibit specially those proteolytic enzymes which has serine residue at the active sites. The examples of these proteolytic enzymes which has serine at their active site are plasmin, thrombin, trypsin, chymotrypsin, elastase and cathepsin. So all these proteolytic enzymes are inhibited by alpha 1 antitrypsin. And all these proteolytic enzymes are also called as serine proteases, because proteases means proteolytic enzyme, and they are called as serine proteases because they contain serine at their active site. And serine protease inhibitors like alpha 1 antitrypsin are abbreviated as SERPINs. Now this clinical features, clinical correlation. Now this alpha 1 antitrypsin is deficiency is seen as inborn or acquired. When there is alpha 1 antitrypsin deficiency, it may lead to a disease called as emphysema. Now what is emphysema? Emphysema is a chronic lung disease in which lungs are damaged. About 5% of emphysema cases are due to alpha 1 antitrypsin deficiency. The incidence of alpha 1 antitrypsin deficiency is 1 in 1000. So deficiency is incidence is more, and it is one of the commonest inborn error. The total activity of alpha 1 antitrypsin is reduced in these individuals. Now what happens? Whenever there is a bacterial infection in the lungs, these bacteria will attract macrophages in the lungs, and these macrophages releases enzyme elastase. In alpha 1 antitrypsin deficiency, this elastase is not digested because of deficiency of alpha 1 antitrypsin, and now this elastase will damage our lung tissues, leading to emphysema. Normally this elastase is inhibited by antitrypsin. If a patient is having antitrypsin deficiency, then this elastase is not digested, and this elastase then, as it is a proteolytic enzyme, it will damage our lungs. Now in some cases of nephrotic syndrome, just now I have told you, where the glomerulus is damaged, the alpha 1 antitrypsin which is present in the blood get filtered and excreted through the urine, leading to acquired deficiency of alpha 1 antitrypsin deficiency. So this is the alpha 1 antitrypsin deficiency and emphysema. Next globulin is gamma globulins. These are mainly antibodies synthesized or immunoglobulins synthesized by reticuloendothelial cells of the body in various conditions. Hypergammaglobulinemia means increased gamma globulin levels. When albumin level decreases due to various reasons, the body tries to compensate the total protein level normal by increasing the production of globulins from reticuloendothelial cells. Globulin levels, gamma globulin levels also increases during chronic infections to fight as they fight against these infections. Next common cause of hypergammaglobulinemia is multiple myeloma. All of us know that our immunoglobulins are made up of 2 heavy chain and 2 light chains. In multiple myeloma, the synthesis of the light chain increases abnormally, and these light chains get filtered through the glomerulus and excreted into the urine, and they are called as Bence-Jones proteins. So this multiple myeloma is a plasma cell tumor. Plasma cells are the cells which synthesizes the immunoglobulins. In case of plasma cell tumors, the plasma cells will abnormally synthesize a light chains only in large quantity. Normally the ratio between the light chain and heavy chain is 1:1. But here in plasma cell tumor, the synthesis of plasma cell synthesizes more light chains. So these light chains get excreted into the urine as a Bence-Jones proteins. This multiple myeloma can be diagnosed with the help of electrophoresis, and in this electrophoresis you will get a Yum band. So this is the diagrammatic representation of electrophoresis. In the upper case, it is a normal electrophoresis where you will see albumin, alpha 1, alpha 2, beta and gamma bands. 5 bands are seen. But if you compare this with the lower case, in the lower case you will see an extra band, 6th band, which is near to gamma band, which is called as Yum band. If we see this Yum band, you can diagnose this case of multiple myeloma. So multiple myeloma is nothing but it is a plasma cell tumor, and in this case the plasma cell will synthesizes excess of light chains only, and these light chains are excreted into the urine, and if you as a Bence-Jones proteins, and if you perform a how will you diagnose? By electrophoresis. In the electrophoresis you will see an Yum band. Next plasma protein is fibrinogen. What is fibrinogen? It is activated by thrombin and it forms insoluble fibrin clot and helps in coagulation. So this is about the plasma proteins, where we have seen albumins and globulins and fibrinogens. Thank you very much.